Hello, Mary. How are you? How are you, Mary? Oh, okay. How- Thank you for subscribing. Thank you so much. I hope you like my art. Okay, that's good to hear. Did you get your KFC too? Oh, nice. I hope you enjoy it. Oh, great. I don't know if you can guess who I'm drawing.
discuss cataracts here. So I briefly want to cover some introductory material, including what cataracts look like, and leukocoria, which is usually the presenting sign of cataracts. We'll talk about congenital cataract, which presents in children, usually newborns. The senile cataract, the most common kind of cataract that you typically see in adults. And then some other causes of cataracts in adults. So a cataract is simply an opacity of the crystalline lens. The lens is the refractory structure that allows for light and the image to project and focus onto the retina. And when people have cataracts, when adults have cataracts, it's not so much a problem that the refractory system is off. It is. But they get this haziness, cloudiness of vision, and that's directly due to the cataract material inside the lens itself. So you can see cataracts have various presentations. This is sort of your typical, stereotypical cataract where you have this opacified material inside the lens. But cataracts can look differently depending on the cause. And I'll show you some different types of cataracts as we go on. That's not so much important to know. It's important, though, to know generally what cataract looks like. Leukocoria is a white pupil, and the designation of leukocoria is important to know because this is often a presenting feature for a patient on physical exam for cataract. Usually we associate leukocoria with children, and that is true. Leukocoria does happen in children, and when it does, it's an emergency. But leukocoria is just any white pupil, and that can be noted by looking through the ophthalmoscope, or it can be noted grossly, or it can be noted even by a parent when a picture is taken. What do we typically get? If we look straight into the flash, we get red eye. With leukocoria, you would get a white eye, or a yellowish colored eye, and that's leukocoria. So in the adult, typically leukocoria means cataract, but the history and the presence of any other symptoms are going to help you determine what the actual cause is. But typically in an adult, it means cataract. In the child, however, there is a differential diagnosis, and we don't go straight to cataract. We do need to rule some things out because there are some things that can be really alarming and really emergent because some of them can be deadly. Particularly what we're talking about here is the retinoblastoma, which is a tumor, usually in newborns, usually no more than 2 years of age, of the retina. And this is deadly if it's not treated uniformly. Other things that leukocoria can be is a congenital cataract, and that is the number one cause of leukocoria in children. Retinal malformations, retinopathy of prematurity, which of course you can see in premature babies, particularly under 30 weeks of gestation. Retinal detachment, and intraocular infections. And as I mentioned, leukocoria in a child is always a medical emergency and demands immediate ophthalmology referral. Okay. So the congenital cataract is a major cause of vision loss in children worldwide. It's also a cause of vision loss in children in the United States, but because of superior care here, cataracts tend to be addressed earlier than in the rest of the world. And as I mentioned, congenital cataract is the most common cause of leukocoria in pediatrics. So leukocoria is a sign, it's not a diagnosis. If a patient has leukocoria, you need to work up the patient for what exactly is causing this white light. About 1/3 of congenital cataracts are hereditary, passed on in families. There'll be a family history, you can get it. Another 1/3 are due to an intraocular infection or due to a vertically transmitted infection like toxoplasmosis or syphilis, or it's due to a congenital syndrome, such as Down syndrome, Fabry syndrome, Alport syndrome, etc. And then the remaining 1/3 are idiopathic. And what you're doing in a child who has a congenital cataract, which is any cataract in a child is considered congenital, is you're determining the cause of the cataract, in addition to referring the child to ophthalmology to get the cataract removed. The symptoms include leukochoria or absent red reflex, and this can be unilateral or bilateral. Really, there's not going to be a lot of symptoms though, because this is a baby and they're not really going to tell you a whole lot. You may also note nystagmus. Nystagmus is fast, sort of beating, abnormal eye movements, and the baby may be unaware of visual surroundings, especially if the cataracts are bilateral. But keep in mind that baby's vision is not very good, especially brand newborn baby, neonate. It takes some time for their vision to develop. So you're certainly not going to put a baby up to a Snellen test. But if they're very unaware of their visual surroundings, abnormal compared to other children of their age, then that can be a sign of cataract. For diagnosis, all pediatrics with leukochoria should have a slit lamp or dilated endoscopic examination, and this needs to be performed by an ophthalmologist to ensure that cataract is the diagnosis. Remember that there are other things that leukochoria can be. So your very first thing after you diagnose or after you note leukochoria is getting the child immediately in to see an ophthalmologist, and the ophthalmologist will make the diagnosis. Generally, you know it's leukochoria. It's probably congenital cataract, especially if the mother has a history of toxoplasmosis or risk factors for toxoplasmosis or has a history of syphilis. Those are common causes, but we have to ensure that this isn't something else, especially the deadly retinoblastoma. Another thing, and you're not really responsible for knowing this for the USMLE, but the morphology of the cataract can also lend some insight into possible causes. I'm going to show you some different morphologies of cataracts. You don't need to know what they are for the USMLE, or really even for practice, because it's the ophthalmologist that's going to be doing this examination. You do need to know, though, is that children with leukochoria, while congenital cataract is the number one cause, they need to be referred to an ophthalmologist for formal examination to rule out retinoblastoma. So the workup is going to, and this is to determine the cause of congenital cataract, if congenital cataract is the cause for the leukochoria, would be routine labs, torch titers, so that's T stands for toxoplasmosis, O stands for other, which can be various things. R stands for rubella, C stands for cytomegalovirus, and H stands for HIV or herpes simplex virus. The O for other can be parvovirus B19, syphilis, Coxsackie virus, although that also falls under C as well. So all of those vertically transmitted infections, a lot of those can cause congenital cataracts, but especially toxoplasmosis, rubella, CMV, and herpes simplex virus. So you'll want to get tests for that. Then you also want to get a urine for amino acids, phosphate, and calcium. That's going to help you determine if there's any congenital disorders, genetic disorders. Mostly what we're thinking about here is something called Lowe syndrome. So this is kind of your differential for congenital cataract. If it's infectious, we're really thinking toxoplasmosis, syphilis, rubella, or CMV. I put some other things on here that can be causes, but these ones in boldface here are the ones we're mainly thinking about. Then these genetic and metabolic errors, these tend to be bilateral cataract, but certainly an infectious cataract can be bilateral as well. And this includes Down syndrome, which Down syndrome a lot of times is diagnosed before birth, but some things that can help you diagnose Down syndrome is just the general appearance of the child. We can have the abnormal stereotypic facies of Down syndrome, and you can get a karyotype if you want to confirm this. Other trisomies like the Tau syndrome and Edwards syndrome can also cause congenital cataract. Galactosemia is routinely tested for on the heel prick newborn screening examination, so you really don't need to do anything extra to diagnose galactosemia, as we do this for all babies in the U.S. Lowe syndrome is what we're looking for when we do that urine calcium, phosphorus, and amino acids. This is rare, but it can be replaced. Then these other things, Alport syndrome. Remember, this is an issue with the connective connective tissue, type 4 connective tissue. Don't quote me on that. And so this affects the ears and the kidneys as well. So these patients will ultimately have hearing deficits and renal impairment. Usually there will be a family history of this because it's X-linked. It has various penetrants though, so it can be X-linked dominant or X-linked recessive, but it is X-linked. Fabry's disease has skin manifestations as well as renal impairment and some other manifestations. That's also X-linked. Coats disease, this is usually a unilateral cataract. Usually it also presents older, not in newborns, and there's a gradual loss of vision. So as far as, Alport syndrome is good to know for nephrologic purposes, for nephrology, but these ones that aren't bold-faced here, Alport, Fabry's, and Coats disease, I don't think the USMLE is going to throw a congenital cataract at you and put one of these as the cause. But it's just good to know that these can cause congenital cataract. But as far as the USMLE is concerned, what you should be aware of is torch, and then Down syndrome, galactosemia, and Lowe's. And there's other causes as well. So this isn't even the gist of it. There's a lot more. But I just sort of put your basics here. The treatment for congenital cataract is surgical removal no later than 3 months of age. I've seen some papers that say 5 weeks to 5 months of age, but typically ophthalmologists will treat infants with cataracts pretty quickly. Most infants with congenital cataracts are at risk for subsequent cataracts because they have this disease process that's going on. And of course, you should also treat whatever is the surrounding cause, the contributory cause to the congenital cataract, if you can. Regular follow-up with ophthalmology and optometry is going to be important, and genetic counseling is useful as well, especially if it's one of those genetic mysteries. Complications include deprivation and amblyopia, although the risk for that is less if you treat the cataract quickly. And remember, what amblyopia is it's a disease of the neuroocular system where you don't create a proper connection from the eye to the visual cortex. So this is exactly what we're trying to prevent when we treat congenital cataracts. The cataract itself is not so much a problem as the complication, which is uniformly going to be deprivation and amblyopia if the congenital cataract is not treated. And the neuroocular system really does a lot of growing and developing in that early period. So that's why we want to get this taken out quickly. Strabismus and blindness are other complications that develop if you don't treat congenital cataract appropriately. Okay, so the more common senile cataract, this is a very common entity in the U.S. About 15 to 17% of all adults in the U.S. over the age of 40 have a cataract to some degree. There's various degrees of cataract to them. So cataract is just this abnormal material within the lens. It doesn't necessarily mean, though, that you're going to have symptoms. This is the leading cause of blindness worldwide, and certainly you would have to have a significant cataract in order to eventually become blind. Most people over the age of 60 will have some degree of cataract. The question is, however, does it affect the patient in their daily life? Risk factors for senile cataract. So look at the name, senile cataract. Senile just means, we like to say senile means old and crazy, but really senile comes from the same root that we get the word senescent, which just means older. It means something that happens with age. And that's exactly what senile cataracts are. They happen with age. So the number one risk factor is advanced age. That's not really something we can modify, though, because everybody gets older. Cigarette smoking and diabetes mellitus, though, are, to a certain degree, modifiable risk factors. So cigarette smoking is always a modifiable risk factor. You can always stop smoking. Diabetes mellitus, you can prevent it once it occurs, once you have diabetes mellitus, type 2. There is a certain amount of damage that's been done, questionable whether you can totally reverse it. Certainly diabetes type 1 can't be reversed. There is an association with hyperglycemia, so untreated diabetes mellitus, uncontrolled diabetes mellitus is probably more of a risk factor than diabetes mellitus that's controlled. Hyperlipidemia, particularly High triglycerides is a risk factor, and then hypertension is also another risk factor. UV exposure has been listed as a risk factor. I didn't know if I wanted to include it here in the senile cataract because technically UV exposure is trauma to the eye. So that might fall more under the traumatic cataract. So although cataracts are reversible because you do surgery and you can remove the cataract material, as the mature cataract, the cataract that's fully developed, remains, the lens, the outer portion of the lens will begin to thicken, and that is not reversible. So that's why this causes blindness, even though if we get to those patients, some of those patients, after we remove the cataract material, they'll still have visual deficits. So this isn't something to wait around on. Once the patient starts to have a cataract and they're having visual symptoms, you need to remove it. So I just want to introduce you to some definitions here. A mature cataract is when a cataract is present and the patient cannot read better than 2200. So technically, the patient is legally blind with this with the mature cataract. That's a fully developed cataract. An immature cataract is a cataract that's present, and the patient can see better than 2200, but they can't see better than 2020. So this is where most cataracts that present in the U.S. will fall. They've got some cloudy vision. Usually they can see better than 2200, but not quite better than 2020. And then you can have a cataract that's incipient, and this just means that the patient has cataract material, but it's subclinical. The patient can see 2020, or whatever their baseline is. So the symptoms of senile cataracts, but really any cataract, really is leukocoria. Visual impairment is the chief complaint, particularly visual impairment that's referred to as blurry, cloudy, foggy. The patient will complain of glare and halos, particularly in the light, when they're looking in the light, because it's the light that's going to cause those halos. Or if they do nighttime driving, they'll see halos as well. There's a myopic shift. So this is interesting. What this myopic shift is it's an increase in the diopteric power of the lens. So the lens becomes to a certain degree thickened, or there's this material inside the lens, and that actually increases the convergence power of the lens. So if you think of what the lens does, it's supposed to appropriately focus the image on the retina. If there's an increase in convergence power, the image is going to be projected before you get to the retina because there's more convergence. And so the patient will actually become myopic. And so the patient may tell you, although usually you need to ask the patient this if you're really stealthy, are you using your reading glasses as much as you normally do? Because with myopia, you will, if there's a myopic shift, a patient who has say they are farsighted, or if they have presbyopia, because they become more myopic, it's going to abate some of their symptoms of farsightedness or presbyopia. So that myopic shift may help their vision as far as focusing on an image. And then monocular diplopia is just simply diplopia, double vision, that doesn't go away when you cover one eye. So they'll have double vision. Usually when you cover one eye, the double vision should go away. But like for instance in strabismus, but with monocular diplopia, that won't go away. It's continue to have double vision. For physical examination, pretty much you're going to be looking in the eyes, looking to see if there's any kind of cataracts. Cataracts are pretty obvious. But you'll want to examine the patient in a brightly lit room. Make sure you do your full visual examination, have the patient read the Snellen chart, compare it with previous exams if you have them. Then use your ophthalmoscope, look into their eyes. Usually cataracts are pretty conspicuous. I do want to emphasize though, The examination doesn't end there. You're going to refer the patient to ophthalmology because they're the ones who are going to eventually do the treatment, and they'll be doing this with a slit lamp device. So just using an ophthalmoscope, that's not enough to formally diagnose cataract. It's enough to tentatively diagnose it, but an ophthalmologist will need to make the formal diagnosis. And like I said before, ophthalmologists can classify cataract into its morphology and how severe it is, and they can also look for any other problems in the eye that can lend itself to decreased visual acuity. And differential diagnosis of decreased visual acuity includes such things as macular degeneration, retinal detachment, vitreous hemorrhage, and these are some things that are a little bit more difficult for the primary physician to see with an ophthalmoscope. So that's why it's important to get these patients over to ophthalmology.
Okay.
So for diagnosis, cataracts, as mentioned, can be apparent with ophthalmoscopic exam, but all patients with cataracts or suspected cataracts should be referred to ophthalmology for slit lamp examination. You should also assess the patient for any possible concurrent illnesses that can contribute to cataract formation. So remember, what are the risk factors? Well, cigarette smoking, you can get that from the history. Hypertension, you get the patient's blood pressure, look at their charts, do your diagnostic process for hypertension, have them come in again, see if if there continues to be hypertension. You can look at their routine labs. You should get definitely a BMP and a CBC at the very least.
Hello, Kelly. How are you?
Patient, a good idea to get a
Yeah, it's been a long time.
see if there's any possible diabetes or prediabetes. Also important, and I didn't put this on here, in a patient who's already diabetic, to get a hemoglobin A1C percentage, because that will tell you
Welcome back.
whether or not they've had hyperglycemia in the recent past, how bad it is. And then a lipid panel is useful as well, again, because hypertriglyceridemia is a risk factor. So those are some things that you can do while you're referring the patient to ophthalmology. And that's useful because if any of these things come back as positive or as significant, then that can be something that the patient can address. They should be addressing it anyway, but something the patient can address to reduce the risk of this happening. So this is just an example of how a patient with cataract may see something.
All right,
So
that's good to hear.
there's this blurriness in the
You're
vision.
welcome back.
It also is a little bit more cloudy, so it's not quite as dark, and the contrast is reduced as opposed to normal. And again, you may see this at night. It may not be as bad if you're looking in dimly lit rooms, but when you're driving down the street and you're in traffic and there's street lights and traffic lights and lights.
Oh, that's
cars,
nice.
you'll note these halos. Patient will note halos. And then there can also, with certain cataracts, there
Did you post it?
yellowing of the vision. So the patient may not only tell you that their vision is cloudy, but that things appear more yellow. And that's just the color of the cataract refracting back to the light. It's not all cataracts are like that.
That's good. That's great to hear.
This is an example of what I mean by immature and mature cataracts. So they get worse, obviously, with time. And then eventually they can become hypermature, and this is where you get problems with the outside of the lens.
Did you post it?
Irreversible. You can remove the cataract material, but the shape of the lens will forever be deformed, and that unfortunately will lead to permanent irreversible issues.
Oh, okay.
Some cataract. These aren't all of the cataract morphologies.
Yeah. As long as you keep practicing, that's okay.
Cataract morphologies that you can see. This here is an intraocular lens, and with most of the surgical techniques that are done, an intraocular lens is implanted. That is done after the surgery to allow patients. The treatment is simply surgical removal of the cataract material by the ophthalmologist. There are various techniques for cataract removal, and that's going to be determined by the preference of the ophthalmologist, and it's based on the type of cataract, location, and other factors. By no means do we need to know anything about determining what kind of surgery to do for a patient with cataract. We just need to
I
know
hope you
that
keep
surgery is
practicing.
the best thing to do for a cataract, and that you need to refer them to the ophthalmologist. Prognosis: 95% of adults will have increased visual acuity
Yeah, you're
following
welcome.
the surgery. So, one of the newer techniques that's done is ultrasound fragmentation, otherwise known as phacoemulsification, and this has fewer complications than some
You
of
can
the
pick
other
some guide from my
older
life.
techniques that are done that are a little bit more elaborate. But that's one way that's done. Lasers, other techniques. So some of the complications include retinal light toxicity, corneal edema, capsular rupture,
All right, thank you so much.
hemorrhage around the choroid, suprachoroidal hemorrhage, and then vitreous disruption. There's other things that can go wrong too. You would be clued off to whether or not there are complications if the patient doesn't have
Yeah, definitely.
dramatically increased visual acuity after the surgery. The vast majority of patients will experience a 90-day difference, literally, after the surgery is performed.
I wish you all the best.
Some other causes of cataract, just to be aware of that these things can cause cataract, are trauma. I alluded to that earlier. That can be things like UV radiation, heat, physical blunt force trauma, radiation, and then it can be an adverse effect of corticosteroids. Usually these are patients who are on long-term corticosteroids. It's another one of the reasons why we don't want patients on steroids for long periods of time, among other reasons. And then certain antipsychotics can cause cataracts, particularly tritiapine. This was associated with development of cataracts in beagles. Apparently that's the animal we tested it on. And then there are skin diseases that are associated with cataracts, atopic dermatitis, and eczema. So some other causes of cataracts. Do you have any questions? Feel free to let me know. So we're going to touch here on conjunctivitis. This is something that you're going to commonly see, especially if you're working with pediatric population or in the adult population, particularly this time of year that I'm referring to now, which is December. Months between November and April are the most common months that people can show with conjunctivitis. So we're going to go
I'm flattered. Thank you so much.
clinical picture of how these patients come in, with some of the causative agents, precipitating causes that cause the development of conjunctivitis. We'll also go into treatment and then differentiate
There are so many artists I look up to,
determining whether or not it's
like Kevin Alcoffo.
determine it's not, because there are some things that you miss that really
He's
benefit.
based in the UK. Very talented artist.
Finally, some clinical strategies that I think are many useful for your lifetime. So the conjunctiva is a squamous epithelium lined also with goblet cells that produce both a somewhat lubricating and protective layer over the inner eyelids and the exposed surface of the eye. And there are different names for the conjunctiva based on where it's at, but the one I want to draw your attention to is the cathedral conjunctiva, and that's the conjunctiva that's reflected over the inner eyelid. Right. So conjunctivitis is an inflammation of the conjunctiva.
Yeah, I can draw a fox,
Or an allergic response. And this is the most
but I'm sure yours would be nicer than mine because you've been practicing how to draw a fox.
patient is going to come in complaining about eye discomfort and itchiness and a red eye or a pink eye. This is also called pink eye, especially when it happens to little kids. And so that red eye is diffuse conjunctival injection, and that's occurring because there is inflammation. And whenever there's inflammation, you're going to get increased flow to the vessels, and so you'll see So what's important, though, while there is
Yeah.
red eye and there is eye discomfort, itchiness, what there isn't, and that's going to help you pin down the diagnosis of conjunctivitis, is that there isn't visual changes, and it's not severe pain. It's discomfort or mild pain. It's not severe pain. There also may be present in conjunctivitis discharge, and usually there is discharge, and it can be watery or it can be purulent. That discharge can dry up, and when it dries up, especially after the person has had their eyes closed for a long time, like after sleeping, that discharge dries up and becomes sticky, and patients will often affirm, if you ask them, that when they wake up, their lids are sticking together in the morning. Conjunctivitis can be bilateral or unilateral. Usually, when it's the allergic conjunctivitis, it tends to be more bilateral. When it's infectious, it tends to be more unilateral. But it doesn't have to be the case. And like I mentioned earlier, it's more prevalent in
Yeah, you're
November
welcome,
and
Kelly.
November 30. Risk factors for conjunctivitis include sarcoidosis, chronic dry eyes, Sjogren's syndrome, which is an autoimmune chronic dry eyes, chronic blepharitis. So the causative agents. So we're talking here bacterial, but not chlamydial or gonococcal. So the most common agents of bacterial conjunctivitis are staph and strep. And so in these patients, there's usually a noticeably purulent discharge. A lot of times there's often periauricular lymphadenopathy. Really, really, really important that when a patient has purulent discharge of the eyes, which usually means bacterial conjunctivitis, as long as there's no eye pain, there's no change in visual acuity. It's very, very important to get a sexual history, because if they have a sexual history, high-risk sexual history, or they have recently had urethritis, or they had urethritis or vaginitis, then the chance of this being a gonococcal
Yeah,
gonococcal
I might as well
conjunctivitis
do it
goes up.
so you see
That
how
would
to draw a fox.
indicate a different treatment.
And then I'll
So,
post it.
very important. If there is
In case you miss the live,
conjunctivitis,
you can
purulent
always see it.
discharge, then you get the sexual history. So, chlamydial or gonococcal conjunctivitis is possible in two particular populations. Sexually
But
active
that's gonna
patients,
take a
and that can
while
be
because
really anywhere from
I have to get done with this
in
drawing
some
first.
instances, anywhere from 12 to 13-year-old, I've seen as young as far as I've seen, I suppose younger theoretically, especially if there's abuse. That's another topic. Sexually active patients or newborns of infected mothers. So in those cases, the newborn is coming through the birth tract and they contracted the chlamydia or the gonorrhea through the birth. So when you're dealing with an adult patient that can talk to you, or older child or adult patient, very important to get the sexual history. When it's a little baby, then you need to get the history on the mother. Has the mother had any past urethritis recently, vaginitis? Is there a positive culture? Usually they do cultures to check the part of the prenatal tests, and also get a sexual history. Okay, so viral conjunctivitis is probably the most common cause of conjunctivitis overall. The most common agent of viral conjunctivitis is adenovirus. Adenovirus also is a common cause of respiratory tract infections. And so this is highly contagious, and usually when a patient has viral conjunctivitis, if you ask them, usually they will have recently had some kind of a respiratory tract issue, stuffy nose, cough, sore throat. Usually in patients with viral conjunctivitis, the discharge is watery, but the watery discharge can also be seen with
Yeah.
the chlamydial conjunctivitis. And in viral
All right.
conjunctivitis, they may have
Have a good
clear
night.
discharge.
Bye.
So that's up in the air. But usually, viral conjunctivitis can be associated with a more watery discharge. You can also see preauricular
See you next
lymphadenopathy
time.
in these patients as well. But what you won't see So there's one that's caused from varicella zoster virus, and remember that is the chickenpox virus. And usually you will see these in children that get chickenpox, and they'll have a general vesicular eruption, which is a typical chickenpox rash, where you've got vesicles of different ages, and they'll also have fever, malaise, and systemic symptoms that are also present. Herpes simplex conjunctivitis occurs typically in newborns of infected mothers, but also can occur in adults. And this is associated with eyelid vesicular eruptions. So you can see the skin eruptions elsewhere, but usually what you'll note is the vesicular eruption around the eyelids. That's going to be present because usually when there is eruption around the eyelids, then it's going to affect the conjunctiva. And then herpes zoster ophthalmicus is essentially shingles that infects the eye. And it infects the eye because that shingles virus has infected that first division of the trigeminal nerve, which is the ophthalmic nerve, and that will affect the conjunctiva as well as the skin that the ophthalmic division is associated. This is associated with that characteristic prodrome. Usually that prodrome before shingles is described as a localized itchiness or pain, and then that's followed by a papular rash and pain. So here's the bacterial conjunctivitis, and what you note here is that virulent discharge. See it usually where you're going to see it most is along the margins of the eyelid and outtakes of the eyelid. And then of course you see notable conjunctivitis. Here it is in a child. You don't see quite as much of the conjunction, but you definitely see that virulent conjunctivitis. So in gonococcal conjunctivitis, typically you're going to see this in newborns. And this is typically associated with copious amounts of discharge. And this is a big deal because when a newborn acquires gonococcus, it can lead to other things that are even more problematic than conjunctivitis. So being aware of the fact that the baby has a sequelae of gonococcal infection is important because we want to prevent other problematic things from happening. So here's viral conjunctivitis. You note the significant injection of the conjunctiva, but what you note is not present is virulent discharge. Here's herpes simplex. So what you note here is that papular rash, vesicles on the eyelids and the surroundings. There's herpes zoster ophthalmicus, so there's that first branch of the trigeminal nerve. Innervates the skin, the forehead, the scalp, and the bridge of the nose. And you see that characteristic of any kind of shingles, there is an abrupt termination of the nerve. So dry eyes is another cause of conjunctivitis. That's going to just come up with history. Patients have a history of dry eyes. That's going to put them at risk for viral conjunctivitis or just allergic conjunctivitis, generalized inflammation of the conjunctiva, the chemical causes, smog, etc. Allergic conjunctivitis is another common cause of conjunctivitis as seen in patients. Usually you'll be able to elicit a history of other allergic symptoms, so allergic rhinitis, seasonal allergies, asthma, atopic dermatitis. In allergic conjunctivitis, discharge is typically absent. However, you may use tears for discharge. So when you have allergic conjunctivitis, a lot of times you'll have excessive lacrimation, and that can be mistaken as watery discharge. So discharge is typically absent, but if there is wetness around the eyes, don't rule out allergic conjunctivitis. Itchiness is a hallmark feature of allergic conjunctivitis. As a matter of fact, if there's no itchiness, you can almost exclude allergic conjunctivitis. So we call that a sine qua non. And so if there is no itchiness, it's probably not allergic conjunctivitis. Itchiness is prominent with allergic conjunctivitis. Itchiness can be present in any conjunctivitis, but it's prominent in allergic conjunctivitis. And as mentioned earlier, allergic conjunctivitis is much more common, much more frequently occurred bilaterally than infectious conjunctivitis. So here you see a child with infection in both eyes. No real discharge here. However, you see a little bit of possible tearing. And it's a cute little baby. And then you see the pink eye. So what is our differential diagnosis for red eye? So red eye is anything where you have that injected conjunctiva. So first off, conjunctivitis. That should be at the top of your differential because it is the most common. And so in this case, you'll have red eye, you'll have irritation, occasionally discharge, purulent or watery, and then that glued eye, where when there is that discharge, it dries up and eyes are closed, and then hard for that glued eye sensation where it's hard to open the eye or get that resistance. But what there is notably is an absence of change in visual acuity. It doesn't affect the patient's ability to read on a Snellen chart. They don't have blurry vision. And often you see conjunctivitis in the winter and spring months. So during this time of the year that I'm recording this right now, November through April, your suspicion for conjunctivitis should be higher in the summer months. Okay, so one of our big differentials is acute anterior uveitis. So this is an infection of the uvea. The uvea consists of the iris, the choroid, and the ciliary body. And when there is an infection there, it is not only going to cause severe pain because there's significant innervation in those structures, but that also, particularly the ciliary body and the iris, affects the pupillary response. And so when there is inflammation in the iris and the ciliary body, you're not able to open your pupil. You're not able to dilate your pupil. So in addition to the red eye and severe pain, typically you will have miosis. And even in dark settings, you won't be able to dilate your pupil. And that's just because of the inflammation. You're unable to open it. They may also have difficulty with fixing. Okay, so in addition to that, of course, they'll have the blurry vision. They typically won't have discharge, and then this pathologic structure called the sleep gate can be present. All that is it's an adhesion of the iris onto the lens, and that's exactly what it looks like. It looks like a little piece of iris, a little piece of colored iris that is kind of intruding. Acute angle closure glaucoma is also associated with red eye and severe pain, as well as blurry vision. But what you will have with acute angle closure glaucoma that distinguishes it from acute anterior uveitis is, in this case, you will have a dilated pupil, not a small pupil. And that pupil can be dilated, or it can be dilated and unresponsive, fixed. And in these patients, in addition to distinguish acute anterior uveitis, that with glaucoma, the patient, of course, is going to have elevated intraocular pressure. And an instrument you can use to measure the intraocular pressure, as long as you use some local anesthetic, get a measurement of the intraocular pressure, and that will help diagnose glaucoma. And then finally, keratitis presents very similarly to conjunctivitis, except sometimes you can have a modest blurriness, change in visual acuity. What's going to really help you distinguish keratitis is two things. One, this tends to most commonly affect contact lens wearers, and two, the red eye is seen more prominently around the iris, around the cornea. So those are two things I'll help you distinguish the two. But it's very common that keratitis and allergic conjunctivitis are mistaken. So to establish diagnosis, it's really just clinical. So you do a history and a physical, and to make sure, the most important thing is that you ensure there's no change in visual acuity. For the most part, you can diagnose conjunctivitis that way. However, a slit lamp examination can be useful. In patients with severe conjunctivitis, especially if it's purulent, or in patients in whom you have done supportive therapy and it's failed, or their conjunctivitis has not gone away, this tends to be a self-limiting disease. You can do a conjunctival scraping, which will help you determine what pathogen. Especially that with a topical anesthetic, and you do a gram stain and or a GIMSA stain. GIMSA stains are done for chlamydia, and then also. But typically, you don't need to do this. Just diagnose it. So what do we do for treatment? For bacterial conjunctivitis, technically, as long as it's not chlamydia and not gonorrhea, then you don't need to do any treatment other than supportive. The supportive therapy is saline lavage, getting rid of that pus, getting rid of that discharge, and then artificial tears for the symptoms. Now I say technically because technically non-chlamydial, non-gonococcal bacterial conjunctivitis is self-limited in healthy and immunocompetent patients. However, a lot of doctors like to use antibiotics because it is a bacterial infection, and in most bacterial infections we use antibiotics, so why not use it in conjunctivitis? And so typically what we use are topical fluoroquinolones, particularly ciprofloxacin, but there are a lot of other agents that are available and perfectly fine to use, such as trimethoprim combined with clomixin B, gentamicin, tobramycin, neomycin. You can also use other fluoroquinolones like ofloxacin, ganifloxacin, and so on. So there's lots of correct choices. Typically, it's the fluoroquinolones that are used. If it is chlamydial conjunctivitis, and that's usually going to be, unlike the other bacterial conjunctivitises, chlamydial conjunctivitis is usually a watery discharge, sticky watery discharge. In the newborn, you'll use erythromycin, liquid, orally, and then in the adult, you'll use azithromycin, orally, similar to how you would treat a genital tract infection. With gonorrheal conjunctivitis, in the newborn, you can use ceftriaxone either IV or intramuscularly. In the adult, you'll use a single dose of ceftriaxone, iron, and then azithromycin. You go, and that is done for a similar reason as to how we treat the genital tract infections, because we want to cover both gonorrhea and okay, so viral conjunctivitis, in this case, it's always supportive. It's artificial tears, unless there's a reason to believe that it is one of those other causes, those non-adenovirus causes of viral conjunctivitis, that would be like your herpes, varicella, or HCO. So if you do suspect herpes conjunctivitis, so they got that those vesicles around the eyelids and on the eyelids, then in that case you should just send the patient off for an urgent ophthalmology consult, because they're going to require specialized treatment. This is outside of our realm of expertise. This is going to be done by an ophthalmologist. If it is varicella conjunctivitis, or if it's herpes zoster ophthalmicus, usually it's the varicella in the children, and the herpes zoster ophthalmicus in older adults. Acyclovir is your treatment choice. And then another one that I didn't really give a whole lot of time, molluscum contagiosum, that can also cause conjunctivitis. And remember, molluscum have that little tiny embellification in the middle of the nodule. If you see those, that can be a cause, so you'll want to remove those, and that can be done in an outpatient setting. Dry eyes, of course, we're just going to be supportive. And then for allergic eye disease, the first approach is going to be either with a topical antihistamine, which you can use levocabastine or betastine, or a topical NSAID, which you can use ketorolac, but there's lots of other things that you can use for that's just giving you two examples. And one or the other will be fine. But if it's refractory and the antihistamine or the NSAID is not working, then you can manage it with topical corticosteroid or topical cyclosporine. In patients who have frequent allergic eye disease, you can manage it, prevent it with a topical probe. Okay, so some clinical strategies. This is something that a research journal came up with that children. So these are factors that are associated with a non-diagnosis of conjunctivitis. So being older than 6 is associated with non-conjunctivitis, disassociated conjunctivitis. If the patient is older than 6, they're less likely to have conjunctivitis than if they were younger than 6. If they present in those late spring, summer, early fall months, April to November, they're less likely to have conjunctivitis than if they present in late November and April. If they do not have purulent discharge, they're less likely to have conjunctivitis than if they were to have watery or no discharge. And if they don't have that nude eye problem in the morning or after they wake up, they're less likely to have conjunctivitis than if they did. So if they have 3 of these factors in the affirmative, then it's a 76.4% chance that it's not conjunctivitis. If 4 factors are present, it's 92.3%. So don't memorize those percentages. Just know these sort of statistics, these associations that are associated with, in this case, associated with the non-diagnosis of conjunctivitis. And this is what I like to use for differentiating red eye, determining what to do. So this is a little algorithm that I like to use. So if you have a patient come in with a red eye, the most important question to ask them is, how's the pain? If they rate 10 out of 10 or 8 out of 10, then you're going to be referring them to ophthalmology because you're concerned of uveitis or glaucoma, which is going to need to be treated by an ophthalmologist in emergency cases. If there is not severe pain, it's just discomfort, then the next question you ask them is there blurred vision? Remember, with conjunctivitis, you should not have blurred vision. So if they do have blurred vision, the next question you ask them is, is it made worse by light, or is light uncomfortable for you? And if they say yes, you're going to be referring them for ophthalmology, but not because of uveitis or glaucoma, because in this case we're more concerned about the corneal alert. So if they do not have severe pain, no blurred vision, then you want to know, is there a discharge? If there's a discharge, it's probably conjunctivitis. And if it's purulent discharge, generally know from the outset that it's purulent conjunctivitis. In that case, we're going to consider their clinical history because it could be either gonorrhea or lesions which may feel conjunctivitis or watery discharge. Their watery discharge, know if there's severe itchiness. Remember, severe itchiness is associated with allergic conjunctivitis. So if there is severe itchiness, probably allergic. If there's not severe itchiness, probably viral. And from the onset, some of those viral causes of conjunctivitis, you can usually tell right away. If there's any kind of rash around the eye, it's probably a herpes or varicella. If there is no discharge, then you can just ask them right away, is there severe itchiness? Yes. Or allergic conjunctivitis? No. Then we're really probably don't have a diagnosis of conjunctivitis here. Probably something like dry eye disease or glaucoma. So what's most important out of this to remember is that conjunctivitis, not associated with severe pain. If it's severe pain, you got to be thinking other things like uveitis or glaucoma, and then should not have a change in your visual acuity. If there's a change in your visual acuity, it's probably something more problematic. So conjunctivitis, red eye, but no severe pain and no blurred vision. And then with the discharge, purulent discharge is associated with bacterial conjunctivitis. And as far as treatments, typically you can treat any of these with just supportive care. However, bacterial conjunctivitis, if it is gonococcal or chlamydial, you'll need to treat that appropriately. With allergic conjunctivitis, you can use topical NSAIDs, you can use topical antihistamines. That will usually clear it up. If that doesn't work, you can move on to corticosteroids, topical corticosteroids, or something even more significant that we try not to use. That we try to keep it to corticosteroids. If you have any questions, feel free to comment below. Corneal abrasions are going to be one of those things that you see with relative frequency, either in the ED or in an outpatient setting. Unfortunately, corneal abrasions are underreported, and so we don't really have a great idea of how common they are, but we do know they're common. So if they're underreported, not only are they common, but they're very common. So this falls under disorders of the cornea. Keratitis involves some inflammations of the cornea, which are infectious in origin. There's also photokeratitis, which is a kind of similar process, but it involves ultraviolet exposure. Corneal abrasion is going to be what we talk about here, and then there's also some other less common disorders of the cornea involving dystrophies, which are primarily genetic, keratotorus, and keratoconus. So the cornea is here in relation to the rest of the eye, and it is consistent with the sclera. The cornea is clear, is transparent, and that's important because we need to allow light to get through the anterior part of the eye, through the lens, and ultimately to the retina, where the image is processed and sent on through the optic nerve. So the cornea, being clear, is made up primarily of collagen. It doesn't have any arteries or veins. It gets its nutrients through the aqueous, and the anterior aqueous is directly posterior to the cornea. The cornea also has some refractive properties. I think it's about 46 diopters. Don't quote me on the exact number, but it's somewhere around there. And that's important for ultimately projecting the image onto the retina. And there are some disorders where the cornea is not shaped properly, and that can result in distorted images. And as a matter of fact, LASIK surgery primarily alters the shape of the cornea to improve the focus of the image. So that's the surgery that you get to correct abnormally shaped lenses. You're not necessarily changing the shape of the lens, you're changing the shape of the cornea to compensate. So this is a cross-section of the cornea. Don't worry about the histology, but it's just good to know that there's different layers of the cornea, so we kind of have an idea of where these things are happening. So this is the outer side, outside of the eye. This is the inner side. This would be the anterior aqueous chamber here on the left. So starting from the outside, working our way in, we have the epithelium. This is stratified squamous epithelium. So these outer cells are flat like pancakes. You can see the flattened nuclei here, and then they become a little bit more columnar as you work your way inwards. Separating the epithelium from the stroma is a thin layer of basement membrane called Bowman's layer. And you have the stroma here, which is the largest layer that's in the middle. And then there's a sort of basement membrane for the endothelium that's called the Descemet's membrane. And then the endothelium is the innermost portion, and that's a squamous epithelium. Okay, so a corneal abrasion is a mechanical or chemical disruption of the corneal epithelium. So we're talking on the outside of the eye here. And this is the most common eye injury among children, and probably the most common eye injury in the general population as well, because you can get them so easily. Lesions heal very quickly. The epithelium has a very high turnover rate. It replaces itself generally within 24 hours. But the time to healing generally depends on how deeply the cornea was injured. So if it was just a couple layers, it'll heal faster than if it were several layers. Typical causes, you can imagine direct injuries, so fingernails, you're itching your eyes, mascara brushes. I have personal experience with that, obviously, but that's where you take that applicator and rub your eyelashes to thicken them up. So it's very imaginable that you can accidentally touch your eye that way. Branches, so if you're mowing the lawn and you run into a branch and it pokes you in the eye, that can cause an abrasion. Chemical injuries like mace is very common. The mace can harm the epithelium, and that will cause a larger abrasion. Blowing dust or debris, extended use of contact lenses, really just contact lenses in general, because if you're placing a contact lens onto your eye, you're actually getting your finger onto your eye, you might get your nail onto your eye. I used to wear contact lenses until I got LASIK surgery about 2 years ago, and believe me, I have extensive experience with having had corneal abrasions. Not comfortable. And then there's also iatrogenic causes. A lot of patients who are disabled on bed rest need help from nurses to keep themselves clean. The nurses may be washing their eyes and accidentally cause a corneal abrasion. The symptoms, typically the patient will present with eye irritation or even pain, but typically this is a sensation of having a foreign body in the eye, sort of a gritty, itchy feeling, but you can't get the thing out of your eye. You can have photosensitivity. Blurred vision is certainly possible, especially since if you have an injury, it will change the refractory property of the cornea in that particular spot. The patient generally will be able to relate to some kind of a trauma to the eye that preceded the pain, but you're usually going to have to milk that out of them. They won't just tell you because they might not know that rubbing their eye caused this, or putting their mascara on, they might have hit their eye. So you should definitely ask, have you rubbed your eyes? Have you used any mascara? Has anything gotten into your eyes? When did this come on? Were you doing anything at that point in time? And of course, it should be relatively recent because corneal abrasions tend to heal on their own within about 24 to 48 hours. So the physical exam will typically require a topical anesthetic. Patients with corneal abrasions, especially if they're severe, especially if it's a child, they won't want you to touch their eye. So a topical anesthetic is useful, and that anesthetic will actually really make a difference for the patient. And that's one of the ways you can tell that it's probably a corneal abrasion. You're just putting an anesthetic on the very outer portion of the eye, and it's only going to hit outer nerves. And if that really makes a difference, that'll help you sort of narrow your diagnosis down, or at least point to the body corneal abrasion. You may note some conjunctival erythema, and a lot of that is not due to the abrasion itself, but due to the fact that the patient has been rubbing or trying to wash the quote-unquote foreign body out. There should never be pain on eye movement. That's a sign of something else. If there's pain on eye movement, then there's something wrong with the extraocular muscles or with the optic nerve, and so that should never be present. Also, there should never ever be corneal haze. That's going to point you more towards a keratitis. This is just on the outside, so there shouldn't be anything inside the cornea. And the pupil should be normal, although sometimes there can be a reactive miosis, but in general it has normal reactivity. You should also inspect the cornea and lids for a foreign body. A lot of times foreign bodies will be darker. They may sit around the iris, so definitely inspect the cornea because there might indeed be a foreign body that's present rather than emerging. In your differential, you can have, of course, other causes of red eye. There's not always significant red eye with corneal abrasion, but if there is, you need to narrow down, rule out the other causes of red eye. Conjunctivitis, typically with conjunctivitis, you're going to have a discharge. And also with conjunctivitis, you should not have abnormal vision. You shouldn't have any blurry vision. Acute anterior uveitis typically has a poorly reactive myotic pupil. And acute angle closure glaucoma will not be a foreign body sensation or mild pain. This will be the worst pain patients have ever had in their life, and they will have extremely blurry vision. Infectious keratitis is another possible cause, but in this case, typically the patient will have a corneal haze. You can, if you're worried about infectious keratitis, if there really is significant red eye, you can do a fluorescein test to look for an ulcer. But in this, with infectious keratitis, there will be ulceration. Ultimately, we will do a fluorescein test to test for corneal abrasion. That's next. But we'll talk about how to differentiate that out. Photokeratitis, another possible cause of this itchiness, this uncomfortable eye. Particularly with photokeratitis, there has been an exposure such as skiing or snowboarding, something outside where you weren't using lenses to protect your eyes from the sun. And then a foreign body, of course, is also on our differential, and that's why we're inspecting the cornea with the foreign body. So here's the corneal abrasion. Apart from maybe a little bit of erythema, we don't see anything wrong with this eye, and that is what you would see in a corneal abrasion. It doesn't look like there's anything wrong. However, when we use fluorescein, we see that there is a problem here. So normally, when you use fluorescein, what you're doing is you're putting this dye onto the patient's eye, onto their cornea, and fluorescein will not attach to the epithelium. However, if the epithelium is denuded, then Bauman's layer is exposed, the fluorescein will attach to that. And so this is all areas here where there was denuded epithelium. So this is very linear, so this can possibly be from mascara applicator. It's another corneal abrasion. And these are a little bit bigger, but this is also a corneal abrasion according to the source where I got this from. This also looks very similar to an ulcer, and your differential is primarily, in that case, going to be how long has this been going on? Was there any preceding trauma? So for diagnosis, we're going to use fluorescein staining, which will demonstrate the abrasion either grossly or under a cobalt blue lamp or a Woods lamp. Sometimes you don't even need the lamp. This is I'm not sure if this is the same eye or not, but looks like the same eye. But here you can see the lesion is present without a lamp, but some of the smaller ones, you may need the lamp to sort of amplify the fluorescence. Under the suspicion of ocular trauma or a retained foreign body, you should consider an ocular CT or an MRI if the object is non-metallic. Obviously, you don't want to get magnetic resonant imaging of anything if you suspect that there's something metallic in there. But this is why you look for a foreign body. If the foreign body looks very superficial, you can try to wash it out with some saline. If that's not successful, you can apply some anesthetic and try to get it out with a cotton tip applicator. Anything deeper than that, you need to send off to an ophthalmologist. For treatment, this is something that does not last very long. Corneal abrasion does not last longer than 48 hours in most cases. So primarily what we're concerned about is pain control. So typically we'll just give the patient PO pain meds, oxycodone and acetaminophen is usually good enough. Some sources I've seen have actually said that you can use topical pain medication, but again, you run into the problem there of reducing or inhibiting the healing process. So I'm not so sure how good of an idea that is. Reassure the patient that this is not something that's going to last very long, should be gone within the next day, and they'll usually be okay with healing plans. Prophylactic topical antibiotics are controversial to use routinely, but there are certain patients in which you would want to use prophylactic antibiotics, especially patients who wear contact lenses. And the reason why is because they're at greater risk for keratitis. So, especially if the patient is contact lens wearer, if they have a recent history of swimming where they can be exposed to amoeba, you'll definitely want to give these patients topical antibiotics, but it's really at your discretion. The antibiotics that are typically used, we want to cover Pseudomonas, so one of the newer generation fluoroquinolones can be used like ofloxacin or gentamicin, but make sure it covers Pseudomonas. And then patient education, of course, avoid contact use until it's healed, because we don't want to expose the patient to any bacteria or fungus or Pseudomonas or amoeba that's on the contact lens. And then use protective eyewear, especially if they got this occupationally. The patient, if the pain does not go away within 48 to 72 hours, or if it gets significantly worse, they should return, and typically they'll be referred to ophthalmology. We're going to talk here about dacryocystitis, and I apologize in advance. You may hear some howling behind me. It's about 20 degrees below wind chill here, Fahrenheit, and we have some really strong 40-mile-an-hour winds, so that may be heard in the background. All right, we'll briefly touch on some anatomy. Then we'll go into dacryocystitis in detail. There's both an acute and chronic form of dacryocystitis. We'll talk about the treatment approach, which is important to be aware of because it varies based on the patient presentation. And then we'll talk about some other problems of the lacrimal system, which are a little bit less common, or I may have touched on them elsewhere in other lectures. So we'll talk about some other things, but mostly we're going to focus on dacryocystitis here. So this is the anatomy of your lacrimal system, and you of course start out with the lacrimal gland, which is located in the lacrimal fossa as part of the temporal bone, part of the frontal bone, and it also extends into the temporal bone as well. This secretes tears over the eye and on the surface of the conjunctiva, and it drains into these two puncta here, which are located on both eyelashes. So you have a superior lacrimal punctum and an inferior lacrimal punctum. And this then drains through these lacrimal ducts and into this lacrimal sac, which is a superior dilation of the nasolacrimal duct. And ultimately, the nasolacrimal duct will drain tears to the inferior meatus. So this is why, for instance, when you're crying or when you're excreting extra tears, you usually have to blow your nose because you have excess tears draining down into the nose. That's the way we get the tears out. Anytime you put something in, it's got to come out somewhere. So the lacrimal gland is provided with arterial circulation by the lacrimal artery, which comes from the ophthalmic artery, and the ophthalmic artery is the very first branch of the internal carotid artery. It receives innervation from multiple sources. It gets sensory innervation from the ophthalmic division of the trigeminal nerve. And then it also receives both parasympathetic and sympathetic innervation. The parasympathetic innervation comes from the greater petrosal nerve, which is a branch of the facial nerve. And sympathetics come from the deep petrosal nerve, ultimately from the Vidian nerve. All right. So the lacrimal gland can actually be seen if you retract the superior eyelid enough. I wouldn't recommend doing this to your patient unless you really need to. It looks pretty uncomfortable, but the lacrimal gland can be seen. And this is the palpebral portion of the lacrimal gland, so it's the more inferior portion. This portion right here can be seen if you retract the eyelid enough. So there's, when you have dacryocystitis, it ultimately comes from an obstruction of the nasolacrimal duct. And there's two different ways that you can get nasolacrimal duct obstruction. It can be primary or it can be secondary. When it's primary, unless it's in a baby, we typically don't know the cause. So there's two patients who get primary acquired nasolacrimal duct obstruction, either little babies or middle-aged to older women. So when it's in babies, it's typically due to a congenital malformation, stenosis of the nasolacrimal duct or something else. So this is in about 5% of babies. And typically when babies present with dacryocystitis, it is due to a congenital malformation. When it's in older or middle-aged women, it's usually idiopathic. And this is something that they are at risk for. Women are at 3 times elevated risk as men are. In secondary acquired lacrimal duct obstruction, we have a cause. So usually it's due to infection, directly due to infection. So it can be bacterial. Usually it's going to be staph. It can be viral, herpes virus, or it can be fungal, and usually that's going to be candida. It can also come from the chronic inflammatory disease, especially Wegener's, as well as sarcoidosis and lupus. Foreign bodies and trauma can also cause obstruction, just due to either the foreign body itself or due to swelling or bony impediment. And then it can also be caused from medications. The chemotherapeutic agents that cause obstruction or nasolacrimal duct obstruction usually aren't used as much anymore, but the topical anti-glaucoma drugs that are used very commonly can lead to nasolacrimal duct obstruction. So here we're talking about the beta blocker timolol, dorzolamide, and pilocarpine, which is a parasympathomimetic. And then radiation can also cause obstruction just due to tissue damage. So dacryocystitis is, in most cases, an infection of the lacrimal sac and the nasolacrimal duct due to obstruction of the nasolacrimal system. It's always due to an obstruction of the nasolacrimal system. When it's acute, it's always an infection. It's always some kind of infection that's causing it, that's present. When it's chronic, it may just be obstruction and no infection, and so there may not be those fulminant signs of infection. So let's talk about this in greater detail. So in acute dacryocystitis, the patient is typically going to present with epiphora, and epiphora just means tearing, excess tears. Not necessarily due to excess production of tears, but the fact that you can't drain your tears, and so they're coming out down your face. And then also a swollen, tender medial canthus. And the medial canthus is just the medial edge of the eye. And this is right where those lacrimal ducts sit. And that's inflamed. And so that swollen, tender medial canthus is due to infection. There's also overlying cellulitis and possibly an abscess. And that cellulitis can extend all the way down the distance of the nasolacrimal duct, so down along the lateral aspect of the nose. You also may see mucopurulent discharge. You usually will. This can either be present just on looking at the patient, or it can be expressed if you gently manipulate the edge of the nose down the anatomic boundaries of the nasolacrimal duct. You should also look for orbital cellulitis. That's not going to be present in all patients. However, when orbital cellulitis is present, you're going to be admitting the patient all the time. So you need to look for that. Signs of orbital cellulitis, among other things, would be, for instance, the patient wouldn't be able to move their eye. So that may be present. But it's very important to look for orbital cellulitis. In severe cases, systemic symptoms can be present, fever. And then in acute dacryocystitis, the symptoms tend to be unilateral, so this tends to affect one eye. Now, on the other hand, chronic dacryocystitis is due to obstruction. There may be a mild infection, but that doesn't have to be the case. So this is due to obstruction. So these patients, you'll have long-standing epiphora because you have obstruction, and that obstruction is either due to idiopathic causes or it's due to an anatomic defect. And so this obstruction doesn't go away, so they're going to have long-standing epiphora. Like I said, you may also have some low-grade swelling or signs of a mild infection, but what sets this apart from the acute form is that this is long-standing, it doesn't go away, and there tends to be a lot less pain than with acute dacryocystitis. Here the symptoms tend to be bilateral, but they don't have to be. So this is a woman with dacryocystitis, and you can see here that there's inflammation at the medial campus, and then down along what appears to be the lateral aspect of the nose. And this might be bilateral here, and that would make sense in this case, that this is a chronic case, because women are at risk of getting that idiopathic primary obstruction. Here's a baby. You can see that this is unilateral, and this is probably due to an anatomic defect. But this is acute dacryocystitis in this case. And then here's another baby. So the diagnosis of dacryocystitis can be made clinically, especially if you're able to express that pus. That's a very, very, very obvious sign that you've got an infection going on. But it can be made clinically. However, certain labs and imaging tests are useful for determining the etiology or underlying cause, since there are several possible causes of dacryocystitis. So you don't have to do these tests, but some of these are recommended. So you're almost always going to want to get a culture of the pus or of the ocular surface. Definitely in cases of acute dacryocystitis, and the reason for that is we want to know exactly what bacteria is causing this, so that if the dacryocystitis does not respond to antibiotics, if we know what the bacteria is, we can change the antibiotics appropriately. There's also something called the fluorescein disappearance test. In this case, what you're doing is you're just putting some dye along the medial campus, and you're looking for it to drain. And if it drains, that's a normal test, because the lacrimal ducts are supposed to drain whatever in that area. But if they don't drain, then it's clear that there's some kind of obstruction. And so this test can be done to confirm or support your diagnosis. Imaging should be done especially if trauma, an anatomical defect, or a neoplasm is suspected. And so the various things that you can get here are plain films, which would be particularly recommended in cases of trauma where you may have a bony problem. CT can be done, and then a dacryocystogram can be done. And that really helps you look at the ductal system and look to see if there's any anatomic defects. When should you suspect a neoplasm? You should always suspect a neoplasm if there's any kind of blood involved. So if you have bloody tears, definitely suspect a neoplasm. And then other tests that you can get if you suspect chronic inflammatory disease, C-ANCA will help you with Wegener's granulomatosis, ANA will help you with lupus. So the treatment approach, in acute dacryocystitis, antibiotics are the cornerstone of therapy, and then any additional management is based on the disposition of the patient. So what you have to look for, and I alluded to this earlier, is orbital cellulitis. If that is present, then you need to admit the patient. They need to be in the hospital. You can also admit them if there's complicating factors, so if the patient appears really ill, if the patient has a compromised immune system, if the patient can't take care of themselves at home, then you can admit them for those reasons as well. But orbital cellulitis, you always need to admit the patient in the setting of dacryocystitis. We're going to give them broad spectrum antibiotics, something like ceftriaxone would be useful, as well as antibiotic drops. And you can use, there's lots of different antibiotic drops, but gentamicin and tobramycin drops are typically used the most. If there's no orbital cellulitis or significant illness, so the patient can be discharged and put on PO antibiotics, but those antibiotics should at least cover penicillin-resistant staphylococcus. So that can be something like Keflex or amoxicillin clavulanate. I tend to not use that ever because it gives patients really bad gut ache, diarrhea. In pediatric patients, you can use Cefepla. And then also you want to be giving these patients antibiotic drops. So we're approaching this systemically, and we are approaching this topically, locally. In all patients, symptomatic treatment is useful, so you give them ibuprofen for pain, warm compresses, helps relieve the abscess if it's there, any inflammation, gets things moving. And then you should also refer the patient for an elective dacryocysto-rhinotomy, and this would be done usually by ENT. There's the dacryocysto-rhinotomy. There's also in the last 10-15 years a balloon dacryoplasty. This is less invasive, and actually it has been shown in some literature to be more effective. And the balloon dacryoplasty is exactly the way it sounds. You're going in backwards through the nasolacrimal ductal system with a balloon, and you're inflating it to expand the nasolacrimal duct. In some cases, if the patient has an abscess, it doesn't respond to antibiotics, they may need an incision drainage. In the case of chronic dacryocystitis, you can use topical steroid drops. Prednisolone ophthalmic is typically what's used, and that's the cornerstone of therapy in chronic dacryocystitis. And this is, again, because typically chronic dacryocystitis is not caused from an inflammation. It's not caused from an infection. So you don't need to use antibiotics most of the time in chronic dacryocystitis. And then again, here you can send the patient off for referral to get an elective dacryocysto-rhinotomy. So some of the other problems of the lacrimal system, dacryocystisio, this is a cystic expansion of the nasolacrimal duct due to an obstruction. So you have an obstruction that's primarily there, and then secondary to that, because of the pressure that builds up, you get an expansion, a cystic expansion of the duct. And this is typically encountered in young children and infants. This can become infected, and if it becomes infected, then it can cause blockage, and if blockage becomes present, then you have a dacryocystitis. Involutional stenosis is that idiopathic nasolacrimal duct stenosis that's typically seen in middle-aged and older female patients. Again, this is idiopathic, and this is what puts older female patients at a higher risk for dacryocystitis. Dacryoadenitis is an inflammation of the lacrimal gland. So this is not anything to do with the nasolacrimal duct. This is the lacrimal gland on that superior lateral side of the eye. And this is typically due to bacteria or virus. The reason I'm not talking about this in depth is because this isn't very common, not in the US at least. So the bacterial causes are typically Staphylococcus or Gonococcus, which yes, can be sexually transmitted, as well as Streptococcus. The viral causes are mumps and the Epstein-Barr virus. So the Epstein-Barr virus, usually when you're going to see dacryoadenitis, it will be in a setting of mono. With mumps, again, we don't see that a whole lot in the US. However, if you're a sports fan, you've been watching in the National Hockey League, the NHL, there have been several players that have come down with mumps in the last few months. And this is probably due to a lack of immunization. And if you work in a family practice setting, you will certainly run into those patients that don't believe in vaccination. This is a problem. There are more patients showing up with mumps and other previously uncommon diseases, now been in several years, and it's because of this growing idea that these that immunizations are bad or a conspiracy from the government or what have you. So it's very important to be vaccinated. This is dacryotenitis is a complication. And then chronic inflammatory diseases, again like Wegener's or lupus, sarcoidosis, they can also cause dacryotenitis. Sjogren's syndrome, of course, is that autoimmune destruction of the lacrimal gland. It can also affect the salivary gland. That's going to cause dry eye, chronic dry eye, as well as xerostomia. So here's a picture of a dacryocystocele. So you know that there's not a whole lot of inflammation going on here. You just have this little cyst here. This looks like it might be the beginning. This was labeled under dacryocystocele, but this looks like it may be the beginning of dacryocystitis. So there's this overlying erythema here, as well as something that looks like it might be drainage here, possibly pus or tears being blocked up that are causing these eyelashes to stick together. Look at it on the other side. This is dacryotenitis. So note that the problems here are on the superior and lateral side, whereas with dacryocystitis, the problems are on the medial side. So this is an inflammation of the lacrimal duct, and if you were to expose the superior palpebra of the patient, you would probably see obvious inflammation. There's another case of obvious dacryocystitis. So hopefully you can see the difference here. Dacryoadenitis is a lacrimal gland infection, very uncommon. Dacryocystitis is an infection of the nasolacrimal duct, much more common. This is on the medial aspect of the eye. So if you have any questions, feel free to write in the comment below. The topic here is going to be diabetic retinopathy. And this is a very important topic in ophthalmology in your clinical practice if you're working an outpatient clinic or even if you're working with older adults as a hospitalist. The reason is because so many people have diabetes. 10% of Americans have diabetes, and I think that's a conservative estimate because a lot of people have diabetes and don't know. Furthermore, that number can only be expected to increase as our population gets fatter. People are going to be more and more likely to develop diabetes as we get older. So diabetic retinopathy is not fully understood as far as its pathophysiology goes. However, what we do know is that it's a pathologic breakdown of retinal small vasculature, and it's due to persistent hyperglycemia. And this damages the pericytes, which are responsible for maintaining the blood-retinal barrier, and it also damages the basement membrane of the vessels. And so because of this, you damage and ultimately destroy the vessels, but not before causing fluid to move out of the vessels, proteins, lipids to move out of the vessels. So this is a breakdown of the retinal vasculature, and it's primarily encountered in patients with poorly controlled diabetes mellitus. But some people may have well-controlled diabetes and still develop retinopathy. But having controlled diabetes and making sure it is controlled will do you a lot of good in reducing your risk of progressing towards diabetic retinopathy. Okay, so this is the leading cause of new onset blindness in adults aged 20 to 65 years. It affects up to 80% of patients who have had diabetes for 10 years or more. Now, a lot of people have diabetic retinopathy and they don't know it, they don't have symptoms, and they may not ever develop symptoms from it. So that 80% number is staggering, but it's not necessarily reflective of how many people really have problems from diabetic retinopathy, but it is reflective of how many people could develop problems from diabetic retinopathy. Um, it all comes down to how well you're controlling your diabetes most of the time. So remember that the leading cause of new onset blindness in the elderly, people 65 or older, would be macular degeneration. So in patients with type 2 diabetes, when they're diagnosed, 40% of patients will have some retinal changes, some vascular changes, some change on an ophthalmoscopic exam that's consistent with diabetic retinopathy, even though they don't have symptoms. 20% of patients who are newly diagnosed with type 2 diabetes mellitus actually do present with visual changes as their presenting symptom or one of their presenting symptoms of their diabetes. That said, all patients with a new diagnosis of type 2 diabetes mellitus should be referred to ophthalmology for a baseline evaluation. In patients with type 1 diabetes, because these are usually children, retinopathy will not present for at least 3 years after diagnosis, and typically these patients don't need to start getting observed by an ophthalmologist until they're in puberty. The best management for diabetic retinopathy is primary prevention, as I've alluded to, so controlling blood glucose level through a healthy diet, exercise, and anti-hyperglycemic medications, and insulin if necessary. So we classify diabetic retinopathy into non-proliferative and proliferative. Proliferative just means that you're growing abnormal blue vessels. So non-proliferative diabetic retinopathy would actually make up the majority, because the majority of people who have diabetic retinopathy actually don't know it. And that would be the people who have background retinopathy. So this is where you show signs of diabetic retinopathy on ophthalmoscopic exam, notably microaneurysms, small hemorrhages, which can be dot blot hemorrhages or plain hemorrhages, and hard exudates, which actually comes from vessels that have been disrupted. So these patients will have mild changes on ophthalmoscopy, but they don't have any symptoms and they don't have any changes in vision, even though they have these changes on ophthalmoscopy. This doesn't require any immediate treatment, just the primary prevention of keeping the glucose level normal, making sure that they exercise, all those things you can do to prevent progression into proliferative diabetic retinopathy. Now, on the other hand, you can have diabetic maculopathy, and that's different from diabetic retinopathy. Diabetic maculopathy is a manifestation of diabetic retinopathy, and this is where you have edema and exudates or hemorrhages that involve the macula. So, whereas with background retinopathy, you have these changes on other parts of the retina, if these changes involve the macula, typically it's going to cause symptoms. And those symptoms are the same symptoms that you would have with any kind of macular problem. Blurring, decreased acuity, darkening, those scotomas that you see in your central vision, and visual distortion. So this would be a symptomatic form of non-proliferative diabetic retinopathy. This is diabetic maculopathy. Apart from using the ophthalmoscope, you can also do optical coherence tomography, and this will better visualize where the problem is and its severity. And maculopathy is the #1 cause of blindness in patients with diabetic retinopathy. So you can go blind with diabetic retinopathy, and you don't have to have the worst form, which is proliferative diabetic retinopathy. All you need is to have maculopathy, and if it doesn't get treated soon enough, and even does sometimes, you can have a permanent decline in your vision or total blindness. Now, the worst form is proliferative diabetic retinopathy.
Hello guys, I'm going to restart the live.
And of course, it's associated
Sorry.
with poor outcome. It's characterized by neovascularization elevation, which tends to be pretty obvious
I have
on the
to restart the
surface of
live.
major vessels. And because
My
those vessels
see you in a few minutes.
are
Thank you
fragile,
so much for watching.